So Stephanie asked me to say a few things about my father. And my father approach to medicine was both passionate and compassionate. Uh, my dad grew up in a coal camp in eastern Kentucky called Fondee. And it was a small but very tight community. His father, uh, Charles Sr., ran the company store for the coal mines. His mother was a teacher. And growing up, again, it was very tight community where everyone took care of each other. And I think those are lessons Dad took with him his entire life. He went into medicine because his father said, Charlie, you ought to go to be a doctor because then you always get to be your own boss. Dad had a very voluminous practice. He would get up in the morning, make rounds, go to the office, make phone calls, go back, finish making rounds, and then do volunteer activities or drive to other hospitals and do consults. He went to nursing homes on Wednesday morning to see his nursing home patients, and he made house calls. Um, Dad had a great memory and intellect. By the time he finished practice after 40 years, he had read every single edition of the New England Journal of Medicine and Lancet ever published. And he enjoyed education. He started out as a full-time faculty for a year, but then always had a senior medical student. And he influenced a number of people to go into medicine with his enthusiasm. Um, Dad loved his patients and was very close with them. He had this golden rule that he taught me. At one time I was frustrated with a very demanding patient, and he looked at me and said, you'll learn that folks are folks, and they'll become your friends. And that's the way he approached it. And his patients were his friends. And even after he retired, he would go out to lunch with his patients and keep in contact with what they were doing. Um, he was not only a hardworking physician, but he also had a well-rounded life. He and my mother had tickets to UofL basketball games for 51 years. Uh, Dad loved the Reds. He went to the World Series twice. Uh, he was in the church choir and was very active with his Sunday school class at the church. He was a great father. Uh, Three of his four kids went into medicine, the older brother Charlie, myself, and Stephanie. Cindy, that was the math whiz, became a CPA. He found a way to come to all of our athletic events and concerts, and he would go to them and then go back to the hospital and do a consult. He taught us to be our best, and again, influenced us so much. We admired him so much that we went into medicine too. But I think one of the most important lessons, again, that he taught me was folks are folks. Everyone deserves care. Everyone deserves love and should be your friend. And my sister Stephanie's going to introduce Dr. Kaatz.
Hello, I'm Stephanie Altabellis, and we're so glad to have Dr. Scott Kaatz from the great city of Detroit here. Dr. Kaatz is a clinical professor of medicine at Michigan State College of Medicine, Wayne State University School of Medicine, and he's a hospitalist at Henry Ford. He's the past president of the Anticoagulation Forum Society of North America in Boston, which is how I was able to track him down. His CV is the longest I've seen at 53 pages, Oxford and all that stuff. So we know he's brilliant. But what you may not know is that he's also a hero who survived the hero's journey to the dark edge of the forest and back. And I love having a hero represent my hero, Charlie Smith. While treating patients early in the stages of COVID, Dr. Kaatz contracted COVID himself. He was placed on a ventilator within weeks of Charlie Smith's death. Unlike most people, after a month with the battle in the ICU, Dr. Kaatz did come off the ventilator, and like a hero, he went back to saving lives. While doing an online CME, I heard 2 lectures by Dr. Kaatz. He spoke on the latest updates in anticoagulation, and I knew immediately that I wanted to track him down and bring him to the Charlie Smith Grand Rounds. Charlie was always about the latest and the greatest. And with that, I introduce the latest and the greatest, Dr. Scott Kaatz.
Thank you very much. Well, what an honor to give this lecture. I am so humbled and so touched. Thank you very much. We're going to make this interactive. If you pull out your phones and click this QR code, it's going to bring up an audience response system. The beauty and the reason I like this audience response system is that you'll get the questions on your phone also. For you at home that are doing this via Zoom, feel free to play along as well. And then if you don't get this right now, because we're going to move along, it will also have the QR code on each question as we're answering it. Here are my learning objectives. I've changed these just a tiny bit after Stephanie and I talked. We were going to do an update in anticoagulation, and then we altered it a little bit. Here are my disclosures. It's basically, I've done a lot of research with the direct oral anticoagulants, with reversal agents, and with new monitoring, and we're looking at a couple of new anticoagulants right now that we're recruiting for. Here's the outline of this, and so we'll get right into this. Again, I'm going to make this case-based and hopefully interactive with you all. So our first case is a 77-year-old patient with pulmonary embolism, no cardiopulmonary disease. I've given you the simplified PESI score. This is a mortality predictor, so this patient is fairly low risk. The troponins are mildly elevated. On the CAT scan, the right ventricle to left ventricular ratio is normal, but on POCUS exam by the intern in the emergency room, they think that they might find that the right ventricle isn't happy. Remember, in pulmonary embolism, you don't die from hypoxemia, residents and students. You die from shock, and the shock is because the right ventricle can't push through the clot, okay? Do you all have a pulmonary embolism response team here, a PERT team? Yeah, so I sat on the PERT National Consortium board for a couple of years. So the PERT team gets the call, and this would be typical of our PERT team, and they go, you know what, patient seems stable right now, it's 10 p.m., we'll come and see them in the morning. Which type of heparin are you going to use? Unfractionated heparin drip in the usual manner, or low molecular weight heparin? I'm going to give you a few moments to vote. There's a QR code. It should be popping up on your phone. If you push that, we will see. No pun intended. I'm not going to do bad jokes like this, okay? But you can watch the horse race up here, okay? Now, I find that I'm going to ask who said, well, we got a tie right now, who voted for that? And I can never get anyone to raise their hand, so I'm glad to hear he was a basketball fan. So I bought some koozies for you if you're brave enough to talk in the group. So we have a 50-50 split. Who said unfractionated heparin? Raise your hand, I'll toss this. All right, here you go. Catch. How come unfractionated heparin?
So the ability to control it.
Yeah. So the ability to control it, because we can turn it off quickly, we can reverse it 100% with protamine sulfate. You can only reverse about 60% of low molecular weight heparin with protamine sulfate. I'm sorry, your name, sir?
Dr. Williams.
Dr. Williams? No, that one's yours.
Oh, okay.
Sorry, but I disagree.
Okay.
That's part of the issue of getting the prize first. Okay, right. So, I think it's unreasonable. If we look at the European Society of Cardiology guidelines, and these are the most focused on pulmonary embolism guidelines, okay, they will recommend that we use low molecular weight heparin as your starting point, okay? Maybe not in this case. And the reason is we have a Cochrane review from several years ago when we see a reduction in recurrent venous thromboembolic disease, VTE, decrease in major hemorrhage, and a decrease in all-cause mortality if you use low molecular weight heparin under over unfractionated heparin. So, but they also go on to say, really the only time that we're using unfractionated heparin in venous thromboembolic disease now is if you think that you're going to do advanced therapies, and with the PERT team on call, et cetera. And that's what I was doing. Having gone to the PERT consortium meetings now for the last 6-7 years and serving on that board, I will tell you across the world, particularly the Europeans, are moving to do that, and our PERT team has been moving to be comfortable with low molecular weight heparin, even if you're going to go in and you're going to either do catheter-directed thrombolysis, almost no one does systemic thrombolysis anymore, or if you're going to do an embolectomy with an extraction device, and they're getting used to doing that. So I think you're going to see that pendulum swing fairly soon. And one of the reasons for that is for low molecular weight heparin or unfractionated heparin to work, it's got to work quickly. We have some signals if you don't get the PTT, or if you're using anti-10, you can do that also. If you're not getting that done quickly, then you have a problem. Here is a study of 400 patients in the emergency room out of Mayo Rochester, and the small white box is what the mortality rates were in hospital mortalities on the left. If you got your PTT therapeutic in 24 hours, the black boxes if your PTT was therapeutic after 24 hours. And we know that the PTTs are hard. They saw that outcome remain at 30 days, an observational study, but fairly well done. Here is a study out of Mass General from about 5 years ago. One of the authors of this study is the immediate past president of the PERT Consortium. Mass General is where PERT teams were born in the world. And what they showed that with their unfractionated heparin at the place that invented PERT teams, only 50% of their patients were therapeutic on unfractionated heparin at 24 hours. The point is it's a difficult to control molecule, so you're not going to get high rates of your patients being therapeutic, where with low molecular weight heparin, you're therapeutic in about 45 minutes. Take home point for this is, I think when you see a VTE, you need to start thinking low. If you're not quite sure, you can start the DOAC, you're going to admit the patient. You need to be ordering low molecular weight heparin unless the PERT team tells you otherwise. That would be my take-home point. My emergency room does unfractionated heparin all the time, and as soon as we see the patients, we switch them over all the time. But that's sort of my take-home point from that. And then this goes back a long, long ways. This is not new news. Russell Hall, that did some of the very, very early low molecular weight heparin trials, so we're going back now into the 80s, early 90s, also showed this mortality trend if you did not get your heparin therapeutic rapidly. Okay, we're going to switch gears now to extended VTE treatment. There's a 42-year-old with non-provoked small, however you want to define that, pulmonary embolism, no transient persistent risk factors. Those are the risk factors that they don't have. Patient's been on full therapeutic treatment now for 6 months. This is actually a real case that I got a telephone consult on. No signs of recurrent DVT. They feel well, no bleeding. The bleeding risk is not increased. What do you want to do to treat this patient? Do you want to say we've completed our 6 months, stop it, continue until 12 months of treatment, because 6 months isn't long enough for a pulmonary embolism, continue the full dose indefinitely because this patient is a non-provoked, or step it down to a half dose, and we'll let you start voting for a moment. And again, the QR code will work on this, and you should be seeing that. And I'm going to continue. I brought more prizes, one for each question. We'll switch this up. I liked all the logos on this. Louisville thing. So, wonderful. Okay, who wants to tell me what they did? I'll throw this to you. All right, let's ask the orthopedic surgeon.
I went with stopping.
Yeah, yeah. So most people were, that's what we're all taught. So first of all, for those, and I will tell you though, that 10% of you to reduce to half dose is what you want to do. So we have some work to do here, okay? So we know that with non-provoked venous thromboembolic disease, that is a long-term disease. Recurrence rates will be as high as 30 to 40% at 10 years. So we switched years ago to now saying that we think about treating this indefinitely. We don't say lifelong, because if the bleeding risk changes, cancer, chemotherapy, ITP, your platelets drop down, you have to get on, etc. Then you get stented and now you need antiplatelets and stuff. Then you will change. So your bleeding risk can change. But if it hasn't changed, you continue this. Here are the guidelines led by Scott Stevens out of Salt Lake. And no extended treatment if it's clearly provoked, okay? Surgical provoked, we don't extend it, okay? We don't do it if you have a minor transient risk factor, okay? Sick in bed, hospitalized for 5, 6, 7 days, came out, we call that provoked, and then it was transient, you're not in the hospital anymore. And so we only treat those for 3 months. But we recommend if you do this, if you don't have any of those risk factors. And then here is a list of what they consider in the guidelines, the major provoking risk factors and the minor. And so this is sort of the nuance in the gray area and the clinical skill that you need to be doing here. So they also recommend half dose. So we have a couple of trials. We have a trial with apixaban that showed that if you took this sort of patient, they got randomized to either stopping treatment at 6 months or to continuing at full dose or half dose. And what we found is you saved a lot of clots if you continued the anticoagulation compared to placebo, and you had similar efficacy but less non-major bleeding if you went to the half dose. So you got some bleeding advantage without loss of efficacy. But this was a trial that was randomized to placebo. We saw the same thing with rivaroxaban, Xarelto, if you compared it to aspirin. And we saw the same thing with dabigatran, which you don't use very much, called Pradaxa. But you're going to start to see more of it creep in because your insurance companies are going to want that to happen because it's generic now in the United States. We saw that. So we saw that signal. So that informed the guidelines. So what you really should be doing is in your patient with a non-provoked VTE, what I do as a hospitalist is I tell those patients right out front, you're probably going to be on this long term. In about 6 months, you're going to talk to your primary care doctor, and then they're probably going to decrease the dose, but keep you on long term. I put that in my notes, so if someone reads my discharge summary, they know what they're doing, and I let the patient know that if someone says we want to stop this 3, 6 months from now, you should be going, no, okay? And we should be thinking about continuing this. That's how I practice that. So that was all fine and good until last month. Okay, so you said being up to date, that's what you asked me for. So this study just came out last month. Actually, while I was waiting for my flight yesterday, I listened to the authors discuss this on a webinar. They're out of France. So the question is, what's the optimal dose of direct oral anticoagulants for extended VTE treatment? It's a randomized trial. It's open label, blinded adjudication endpoint. They're looking to see if the full dose and the half dose are similar, or what we call statistically non-inferior for efficacy, preventing the clots. And then secondarily, they were looking to see if it was safer with a lower dose than a higher dose from a bleeding standpoint. So they're asking 2 questions in this trial. The patients are 2,700 patients, everybody had been treated for 6 to 24 months. Okay, so the standard treatment has been down. Now you're at the decision node. Now, unlike the previous trials that informed the guidelines, where the previous trials were talking about they were randomizing and comparing to either placebo or aspirin, this is, we've already decided these patients, we're going to treat them indefinitely. It's which dose we're going to use. So it's not should we do indefinite. That decision's been made in these patients. Now it's which dose should we use. They used apixaban, Eliquis, because you got to pick one of these to do in the trial. So they did the half dose, the full doses, the comparison, and the outcomes are what I talked about. And follow these patients for about 3 years. So nice long follow-up so we can see what's happening in the long-term horizon. A lot of trials will just stop at a year. They did a nice job of following these patients out far enough. Here's where it's going to get confusing. Okay. If you look at the curve on top with the symptomatic recurrent VTE, you probably don't need to do any statistics to say those two recurrence rates look like they're similar, so I'm going to buy that. But it did not meet the statistical parameters that are fairly complex to do this. If you get really robust from a statistical standpoint, I listened to the statistician yesterday morning discuss this. The rules are you can't test for safety if you didn't prove your first point. It has to do with statistical quote cheating, etc., like that. They did it exactly robustly how they're supposed to do this. So with that, then you're not supposed to be able to say, and they did not test or did not put a p-value on this reduced dose. The clinically relevant bleeding rate was 9.9% versus 15.2%. If you do that math, that's an absolute difference, about 5 number needed to treat to save a clinically relevant bleeding in the range of 20. Number needed to treat for 20 is really, really low. That's really robust in most of the things that we do in internal medicine. So how do I use this? Well, we just had the anticoagulation forum meeting last week in Washington, D.C. And so we talked about this with a whole bunch of leaders and experts, i.e. the best experts in the country, and actually some international folks who read this. And how I think our group consensus with those leaders are doing this is that I'm still very comfortable with dropping down to half dose. That's what I've been doing for years and years and years. And the reason for that is because that statistical parameter wasn't reached, is because the recurrence rates were really low. What reassures me is I got a recurrence rate of 2.2% at 3 years if I do the low dose. That's really, really low. And what I'm going to do is I'm going to save 5 bleeds I'm going to save a bleed for every 20 patients that I do that with. And shoot, I see that many patients in a year in my hospital medicine practice. So take home point is, even though you're going to start to see some news, because this is real recent, that maybe you shouldn't drop down, that's not how I'm addressing this. And actually the lead author also kind of gave the wink and the nod and says, yeah, that's kind of what they're doing also clinically. Okay, cancer-associated venous thromboembolic disease. This is your 56-year-old female with cancer associated with an intermediate risk pulmonary embolism a year ago. They had breast cancer 5 years ago, lung cancer 2 years ago. They finished their 6 months and then they went to step-down therapy. They got normal liver and kidney function. Now, what I will tell you, so I'll bring this up so you can vote on what you're going to do. I will tell you in all of these trials, cancer patients were excluded because the thought is the cancer patient is so high risk for recurrence that there wasn't an appetite to try to do the lower dose. And this study is trying to answer, should that be done? See if we can get another volunteer. All right, we got the majority of saying drop down or stay drop down to 2.5. Who said that? Ooh, it really says basketball on it and everything. You guys make me a tournament this year. All right, we'll just leave that on the table until okay. And so this is a case that I got consulted for from one of my partners, and I recommended in this patient that we go back to 5 milligrams and go back up. And it was because at the time, this trial was the only trial to address that question. So this is just asking that exact question. Can we drop down? Here's the question. It's a randomized double-blind trial. It's led by Rob McBain out of Mayo Rochester. 360 patients, so fairly small study, but also not tiny. The intervention was half dose of apixaban. The comparison is full dose. The outcomes are what we would expect. And when we look at the results, the top graph showed no difference in, there was no difference basically in recurrent VTE, major bleeding, or in mortality. Let me point out here this mortality. This is a 12% mortality, all-cause mortality at a year, okay? Now, most of that death is from cancer because all these patients have this. What you have to remember, however, is if you have your patient with a cancer and then they get a VTE, that is a horrible prognostic signal. Mortality rates are anywhere from 12% in this. We have mortality rates as high as 40% in some cancer-associated VTE trials at a year. It is a bad thing when your cancer patient gets a DVT or a pulmonary embolism. So the reason I said stay on 5 milligrams in this patient is because we saw that it's a small trial. It wasn't probably powered to sort that out. It wasn't convincing to me. I changed my mind 12 days ago in this paper in the New England Journal. Okay, so this is an important one. Asking the same question that we've been talking about. It's a randomized, it's double-blinded. Here they have blinded the doses of, and they used apixaban. It was a non-inferiority. We've discussed that before. Now this is a larger study, 1,700 patients, global, 121 centers, 11 countries. What's very interesting is about, it included DVT and PE. And for the pulmonary embolism, a third of those pulmonary embolism were incidental pulmonary emboli, okay? So the lung cancer patient that's getting a restaging or a progress on how the chemotherapy is doing, they get a CAT scan, and then the CAT scan, as you're looking at the chest and get some contrast to look at what the tumor is doing, you find the pulmonary embolism, okay? So there's been a question on whether that should be treated or not. Everybody is treating those, and it was a big proportion. So that proportion is represented in this group. And that's a very common finding in cancer CAT scans. I see them all the time as a hospitalist. The intervention is the half dose, the comparison is the full dose, and the outcomes are, so the first one is on efficacy. So if I drop the dose, maybe that's not enough. This patient is high risk for recurrence. They have active cancer. So I got to make sure that I'm not worse or I'm non-inferior. So it's safe to do that. And then, of course, the leading thing, the reason we want to drop that is because can we decrease the bleeding risk? Because lots and lots of bleeding in sick cancer patients. No surprise there. And the platelets are dropping periodically with chemotherapy, etc. And they followed these patients out for about a year. Here's what they found. You can see the graphs up there. But the recurrence rates were reduced dose was 2.1%, full dose 2.8%. You got to look at the statistics. You got to look at the confidence intervals. I don't think anybody thinks that lower dose will decrease your risk. I think this is just the chance of moving it around. But it was shown to be non-inferior, i.e. similar in rates of recurrence. So that's good news. But they dropped the bleeding. They dropped the bleeding rates by 3.5%. Number needed to treat to save a clinically relevant bleeding is about 30. So for every 30 of these patients that you drop that down, one of those patients in the next year will not experience a clinically relevant bleeding. So I literally changed my practice 11 days ago, and I am now dropping down to 2.5, to the point that as I made these slides, then my colleague that had just called me like 8-9 months ago, I just gave, by the way, grand rounds at my shop 2 weeks ago and told everybody to stay on full dose. And then this came out. And so I circulated that to the residents, say, never mind what I said. It literally 14 days ago, I gave grand rounds at my shop. Never mind, things have changed, okay? So I hope that's up to date enough for you. Okay.
We'll take it.
All right, great. I get this question all the time. Treated one of these patients on the phone yesterday afternoon. Fortunately, I had that call before I did the Angels MV tour. So I think I was right. Okay. So this patient has an isolated, yes.
Or whatever they've been on anticoagulation and half dose, you incidentally find something else. So in my mind, they developed that clot on the half dose. I would have thought of it as a failure.
Yeah, okay, great question. So here was the issue. All these patients in that trial had been treated and were still on full dose, okay? And to get in that identifying first clot was, some of them were incidental. So that was the original clot. Then you take them, they're treated for at least 6 months on full dose. And then after that, they randomize them to stay on full dose or decrease the half dose. I think you're asking a different question. What do I do with my cancer patient that's already being treated? Okay, and even if they were a half or full dose, and what would I do now if we did another CAT scan and we found a new clot? They already had one. This was their second clot. On that patient, if they were on half dose, I would kick them up to full dose and call that a quote failure of the half dose. After I make sure they're actually taking their anticoagulation. Yeah, well, no, because that will happen a bunch. Then I would call that a failure, and then I would kick them up. Okay, and then the next logical question comes up: what do I do if they're on full dose and they have a breakthrough, which will be high in this case, but early, particularly in the first 6 months or so, you'll see a lot of breakthrough. The original trial, when we compared warfarin to low molecular weight heparin, at a year, the recurrence rates were 18 and 9%, even on treatment. I think that was a 20-year-old study. Our chemotherapies, our treatments have changed in cancer, so we're seeing a decrease overall in the DTE burden. But then what you would do is you could talk about putting them on warfarin, but warfarin in cancer patients is really hard. You would probably switch them over to low molecular weight heparin. So to simplify, half dose failure, go to full dose failure, low molecular weight heparin.
And then the last permutation to that is after they've completed 6 months, because they were a failure, we could keep them on high dose, or we could default to them.
Oh, no one knows, and you'll never have them. Well, then I think you bring in all the clinical parameters. Then I think, how thrombogenic is this? Okay, so is this, and for that trial that I just showed you, most of that is breast and lung, breast and colon and lung, because those are the common. Okay, but what do I do if I have the really high thrombogenic? What if this is metastatic pancreatic cancer? Okay, that one I might still stay just out of, because it makes sense. Of course, just because it makes sense doesn't mean that's the way it works. But we all do that all the time in practice, right? I go this, nobody knows, we're in a complete gray zone, and you take your best guess and do shared decision making with your patient. Did that answer?
Yes.
Thank you very much for the question. Okay, isolated calf vein thrombosis. This is where which basically is the easy way to read the Doppler is that it's not in the popliteal or north. If you don't have it in the popliteal, whether you remember which veins are there, which are muscular, which are the other veins, doesn't matter. If it's not in the popliteal, it's isolated. So how do you want to treat this patient? give it just a moment. So, and this is a very, very common scenario. Yeah, so lots of folks will do the serial ultrasounds, and that is something that we recommended as an option on a call that I had yesterday. Here's what the ACCP guidelines say, is that they say you can do serial image, and then the next sub-bullet says with severe symptoms or risk factors for extension, see text. I'm going to show you the text in a minute. And then the other thing with the serial ultrasound, so the way you do the serial ultrasound, which is what most people have voted for, is that you do it at 1 week and 2 weeks. We have studies that have looked at this in your rate of extending or going from an isolated distal to a proximal clot after 2 weeks is very small. So about 7 days and 14 days. Now, the pragmatic issue is you got to get a patient that's going to be able to come back and do those 2 ultrasounds and has the ability to do that. And then if the clot got bigger, well, it's extending, so you have your clue, so anticoagulate now. Certainly if it gets to a proximal, if it goes up into the popliteal, you are no longer having an isolated calf vein thrombosis, and all those patients get treated for a minimum of 3 months. So that's how you will use that ultrasound if you're going to go that route. Here's the list of, on the left, on choosing to decide whether you're going to anticoagulate or do serial ultrasound. I look at that long list and I go, I don't see very many patients that don't have one of those. So I tend to treat most of my patients. We've run a DVT team for decades when my clinical nurses. Now, we actually have the Doppler ultrasound folks call us. We review the case, and then we call the primary care doctor or the orthopedist. This patient yesterday, we couldn't get a hold of them. They just had knee surgery a couple of weeks ago, and we will discuss with them, and then we try to do most of the work and help folks out and just hardwired. We have that hardwired into our system to make that. Here is where you really do shared decision making, but it's the symptom. The case I saw yesterday wasn't post-operative, but they had this and they were complaining their leg was hurting a bunch, and they were an Uber driver, and they said, I think I want anticoagulation and get this better, because if it's bad in a week or two, I could be losing income from my job, etc. So again, take in the patient's preferences is what you have to do with this. But here you have choices. More importantly, the patient always has choices, but here they're really doing true shared decision making. Some diseases you really got to do this, is the only treatment. Okay. Sub-segmental, as we're talking about small clots, we talked about a small clot in the leg. What are we going to do with this small clot in the lung? 67-year-old, shortness of breath, elevated D-dimer in the ED. They get a CAT scan. It's got 2 sub-segmental pulmonary emboli. The Wells score is normal. The simplified PESI score is. So this is a patient that you can actually send home from the ED. And more importantly, they don't have clot in their legs. You have to look for that. Would you anticoagulate this patient? 2 small sub-segmentals. And the history of this is, remember, when the CT, I'm old enough to know when the CAT scans were becoming available to do CT for angiogram. And, you know, it used to do this. The patient would have to hold their breath, and, you know, the scanner go, keep holding your breath. Great, I have a pulmonary embolism. Thanks for telling me to hold my breath. You know, and it would scan it, right? And you'd have 2 detectors, and then we got 4 detectors, and the computer started getting better, and it was how many detectors you can put. Now I think you almost got to put a seatbelt on the patient, because they have to zing right through that thing. The computer's fast enough to get the images. So what you want to do there is, as we progressed over time, now we can see these tiny, tiny little clots. Here is the important thing to remember. If you see subsegmentals, I always call the radiologist. I don't talk to the radiology second-year resident. No offense to the residents. I go, let me have your faculty. Tell me when you go. Review this case, run it over with a case, call me back, okay? I want to know, do you really see that, okay? Because these are so tiny and these are just a little wisp. If you haven't done that, my experience, 15% of the time, they'll come back and go, nah, I don't see what my partner saw, or I really don't think it's there. And if this is a patient that has high bleeding risk, I want to make sure that I'm not committing them to at least 3 to 6 months of anticoagulation with high bleeding risk. So I'll call and have that conversation, because the radiologist, to their credit, they don't know what's going on with the patient. You ordered a CAT scan, they got a film, they read it, they give you a report. Yes.
Does this, but we are using some AI support that initially generates something that the resident, the second year resident is looking at, and it circles it for them. And then I think you're more likely to have some of those over calls as well.
Yeah, we do that. In fact, as soon as I walk out, I will turn mine on, because I'm recruiting for a trial that needs right ventricles at strain. And not only that, the AI program that I get will give me the right ventricle to left ventricular ratio, because that's one of the inclusion criteria. Yeah, I agree. AI said that. Oh, must be right. And I just sign off on that. Yeah, so very good. I agree. That's even complicating this a bit more. But I always make a call, because you'll find a lot of times you actually don't have a pulmonary embolism, and then life got a lot easier for your patient. So that's what I do. But most of you want to treat this. So that's not, by the way, what the guidelines say to do. Okay, the 2021 American College of Chest Physicians will suggest just surveillance in not treating those sub-segmental pulmonary embolia. To that credit, this study then came out after that guideline was written. This is just a systematic review from last May, okay? And it was really taking all the studies that were comparing either all of these studies were observational, non-treated patients with sub-segmental pulmonary emboli. They followed them all over time to see what the recurrence rates were. There were 7 trials. Here are the 7 trials listed. In many of these, you see where it says recurrent VTE here, 0,11111, until you get to Gregorio Legal out of Ottawa's study, which was in the Annals of Internal Medicine a couple of years ago. And in that study, which was done very well, Gregorio is one of the leading researchers on the planet in this field. And what their team found is that if you had a single subsegmental, here down at the bottom, your rate was 2.1%, but the confidence intervals are there as well here, and it went up to, might be as high as 5.5. This is not a comparative trial. This is just seeing what happens with these patients. And if you had 2 or more subsegmentals, the point estimate was 5.7%. When this study came out, I was on the fence. I was actually following the guidelines and observing most of those patients and not treating them. I switched my practice that day based on this data. If you take a look at this systematic review from last year, the authors will say, geez, when we pool all the studies together, we don't see that signal that we should maybe treat. The recurrence rates are low. But if you look at it, then go and read each of the individual studies and look at the methodologic rigor, the Annals paper trumps that. And also, they got over half of the patients in the systematic review, 167 patients out of the 266 in the trials that I've highlighted. So what I do is I disagree with the author's conclusion of this systematic review, and I can continue. But if you see where the pendulum keeps swinging back and forth, this would be an article that would swing you maybe away from that, but I'm treating those patients. Okay. Obesity question comes up all the time. 42-year-old non-provoked small pulmonary embolism. No, this is non-provoked. The patient weighs 140 kilograms. What are you going to use? We obviously see lots and lots of these patients. I'll give this just a couple more minutes. I know that's just one person that's voted. Yeah. Yeah, and the warfarin argument here would be is because I can adjust the INR because am I going to get high enough levels and then am I going to get enough pharmacodynamics with the direct oral anticoagulants? And then low molecular weight heparin, you could make the same argument because there you just keep increasing the dose as the weight increases. So I agree, this all over map. And so here's what is really handy. The International Society on Thrombosis and Hemostasis, the leading organization globally for clotting stuff. Really, bottom line, as they said, we have enough observational data now to show that you can probably go ahead and use the direct oral anticoagulants regardless of the weight, okay? Their previous guidelines had drawn their line at a BMI of 35. They said, take the guardrails off. Now, what do I do when I have that, super obese, whatever that determination, what do I do with the BMI of 60? I'm not sure I'm willing to extend out that. And when I get nervous about that, wherever that line is, and I can't tell you what it is, it's sort of, I know it when I see it, I think, is then I will use warfarin only because I can rheostat the INR. That's what I'm using. And I've had some patients go, I'm just not doing, as I said, because my weight is a hindrance, lots of other things, getting back and forth to get INR testing becomes impractical for them getting in and out of a vehicle to do that again. So we do shared decision making. But starting point is don't let weight preclude you from what you're from prescribing a DOAC. And what's interesting in the American College of Cardiology, then for atrial fibrillation just came out 15 months ago and said the same thing for AFib for stroke prevention as well. So we have the guidelines for both AFib and VTE aligning now. Let's switch gears. 76-year-old AFib, hypertension, diabetes, CHF. So that's a reasonable CHADS VAS score. They're on either DOAC. They got normal liver and kidney function. They're going to get planned spinal anesthesia, okay? So, and in our pre-op clinic, we have to make this recommendation all the time because our division of hospital medicine does that. So what are you going to do? I understand the real answer is whatever anesthesia says we're going to do is what's going to happen. But if you got to write a note 2 weeks before surgery and you're seeing the patient and you get asked these questions all the time in primary care, and at least in our group, our surgeons are sort of asking us this question also from a bleeding standpoint. I say, oh, good, so everybody's completely all over the map. Same thing that happens clinically at my shop. So good. So let's chat about that for a moment. So first of all, because several of you said bridging. There is virtually no reason to use low molecular weight heparin bridging when you're stopping and interrupting a direct oral anticoagulant. You are trading the onset of action of both drugs are almost the same. The offset of action of both drugs are almost the same. Skip thinking about half-life, just skipping about when they start and when they start. So do you have to do that with warfarin when the on-ramp is, the off-ramp is 5-6 days and the on-ramp for warfarin is 5-6 days? Sure, you got to use low molecular weight heparin there. But it makes no kinetic sense to do that with DOACs. Hence this fairly strong statement. And here's the explanation here. What we use, and then if we look at the 2022 American College of Chest Physician guidelines led by Jim Duquetas, who led the study that informed this guideline, is here's what they are recommending. And it gets really simple. And the difference between the guidelines is that the American College of Chest Physician guidelines say think in days, where the American Society of Regional Anesthesia guidelines that were just updated 2 months ago say think in hours because it bases on half-life. My problem with hours is when I see a patient 2 weeks before surgery, I don't know what time of day they're going to have surgery. So I don't know how to set hours. Shoot, When I get consulted at 4 o'clock in the afternoon for my hip fracture patient that's going, later on that evening, or maybe the next morning, I don't know what time. So I don't know when it's gonna go. So hours from a pragmatic standpoint doesn't seem to make sense, where you're pretty sure you got the day of surgery locked in. So it was built to be pragmatic like that and very easy. High bleeding risk, hold 2 days before. Low bleeding risk, hold 1 day before. Okay, make it simple, easy to remember. Now, if you hold a full day, remember, you're holding about a day and a half for low bleeding risk procedures. 39 hours, 39 hours. And if you're holding for 2 days before, it means that last dose is probably evening of pre-op day 3. So now you're holding about 63 hours. Okay, and then there's a whole bunch of consternation between the two groups over 63 hours versus 72 hours. That ain't a lot of time. That's less than a half-life. So I'm not sure that it makes a lot of sense. If you follow this protocol, your bleeding rates were low. I will skip through this. This is the ASRA guidelines that just came out January 29 of this year. Yeah.
So, but you're talking just atrial fib, right?
Well,
In
these
this case.
studies were done in atrial fibrillation.
We're
Great.
talking valve, we're artificial valves, we're talking just AFib.
Right. Well, because we're talking about a DOAC. So you're not talking about mechanical valves because you never use DOACs and mechanical valves. And then most everybody is extrapolating this hold times also for your VTE patient. Okay. Now with VTE, what the ASRA, the anesthesia guidelines will say, if you're on that lower dose, because we've just talked about 2 studies now that you can use lower dose after 6 months for VTE, then they're saying you can shorten the hold times, which makes sense because you've got less drug on board with a lower dose. Okay, right. No, but with mechanical valves, that's a whole different warfarin, and then whether you bridge or not is a long conversation. Yeah.
Anesthesia in Louisville says 3 days, and they still use more even after 3 days of Eliquis.
Yeah. Well, sure they will when we think that. So it really gets into then with the oozing, with the Eliquis is what are the levels? So let me skip through here. So fortunately, we have this study from March 12th. What was that? Oh, goodness. This is an old study now. This is 3.5 weeks old. Okay. And the question really is, in a pilot trial in 159 patients, what is the difference in levels if we use either what's called the pause protocol, hold for a couple of days, or if we use the ASRA protocol where we hold for 72 hours? Now, no one knows what a safe DOAC level is, but lots of folks will talk about that being less than, 30. And here, whether you on the left, ASRA, American Society of Regional Anesthesia, or pause study, days versus hours, the proportion of patients that had less than 30, you can't measure less than 20. Instruments don't go down less than 20, was the same, 95, 94%. So this study shows you, at least from a drug level, that you are similar depending on which we have. So this, whether we got to do this way or another, as we're building protocols, it probably doesn't matter. Again, only in 159 patients. And the issue that I have with ASRA, now I worry about clots, you worry about bleed. So I get that, there is a balance. But if I have that really, really high risk clot patient, if I'm using ASRA, I'm going to hold about 7 half-lives. And so what I do with my patients that are really high risk, Chad's VAS score of 1 million, big pulmonary embolism, last week, then I'm on conversations with both my surgeon and my anesthesia to say, I know what you want, but let's make sure you understand my side of the coin. And then my surgeon says, no, Scott, you really don't understand. We're going to do a 27 level spinal fusion, okay? It's gonna be a big surgery, okay? So, nah, you can't have any drug on board. So that's what we do, and I have those conversations when I work in pre-op clinic all the time to do that balance. But I think the headbutting that's been going on is probably unnecessary. So I tried to go through those quickly and save some time for questions. And again, really touched for the idea of this lecture. Thank you very much.